as nicely presented by all of you, we're very fortunate that we have a plethora of effective evidence-based interventions, and you nicely outlined them all in your discussion. But unfortunately, we still see big gaps between the evidence and real-world implementation. So, Hanne, I would like to ask you to share your experience and also your involvement with international stroke organizations on how we can actually make sure that we deliver intensive secondary stroke prevention strategies to our patients. We detect and treat post-stroke complications, but at the same time, we increase patient self-empowerment. So what is your experience, and what is the pathway we are taking, and what is the pathway we should be taking?
Well, this is a difficult horizon, but what we are all working in every day. But we have to be aware that at the moment, about 1 in 5 strokes in Europe is actually a recurrent stroke. So there's something to work with. Of course, we all know that whatever we do, it will not be 0, but 1 in 5 is probably too much. And if we look at the organization over the European countries, very, very few countries actually provide comprehensive and systematic follow-up, or even any kind of follow-up after stroke. That is in contrast to what is offered to people with cardiac conditions in most countries. And I think that is very much the basis why we have these issues with the follow-up. And I think that is very interesting also based on the fact that patients after stroke do not only have the issue of secondary prevention to optimize treatment, but also to ensure risk factor control, also those not treated pharmacologically. But there's a lot of other needs and gaps. Often they have mental and cognitive issues resulting from the stroke. They have later drops in functioning, and they may need to be returned to some kind of rehab. They have issues that may be very significant with participation, and that may be in family, that may be in society. They may develop pain, spasticity, that needs treatment or could at least benefit from treatment. There may be the carer situation. There may be the returning to work or not returning to work situation. So there's really a lot of issues to be followed up on that are pretty stroke specific and that are often lost. In the action plan for stroke in Europe, our rather simple approach on what to do is to use the post-stroke checklist, which is actually a World Stroke Organization tool, which is well validated, and also developed for nurse consultations, and very practical because it includes defined actions for what to do if everything is not okay. And this post-stroke checklist includes all of the above. And that pretty much goes around what are the issues for most patients. Because what we see if we do not follow up on the pharmacological treatment is that patients may not have understood that this is lifelong treatment. They might feel something uncomfortable, and they may think this is a side effect. Often side effects are not real side effects, like the muscle pain that is also very frequent in control groups in statin trials. There's a lot of issues that need some kind of professional advice to support the patient in actually following up on the secondary prevention, but also simply to have the blood pressure or the lipids controlled. There are also other models of doing this. I mentioned the post-stroke checklist, which is kind of, as a rather simple thing that can be implemented in most countries. But there's also an excellent case model is the Austrian one, the stroke card, which is kind of a deluxe version of the post-stroke checklist. This has also been tested in a very nice trial, also called Stroke Card Trial, published in Lancet a few years ago. And this consists of during the admission, patients are given access to certain tools, including access to the MyStroke website, which includes a lot of educations and potential empowering elements. And then this is followed up at 3 months by a multidisciplinary 2 or 3 hour consultation, including reassessment of stroke cause and follow-up on secondary prevention, as well as educations, and carers are also included in this in this consultation. And the actual benefit from the stroke card intervention trial was rather impressive, and very impressive, taking into account that this has actually not been implemented, to my knowledge, nowhere else than in Austria, that the intervention reduced the risk of major recurrent events by 1/3, and it significantly both improved self-reported health-related quality of life and independence. So this may be a deluxe model, but still, if we look at giving access to a website and a bit of information during the admission, of course, on top of the other things that we all do or should at least do, including lifestyle counseling, and one long consultation after 3 months, I think this would be cost effective. I looked if I could find any calculations on it, but I couldn't. So I think that we need basically to set up and implement some kind of systems to follow up on patients after stroke. And I think that the problem about just having one last consultation after 3 months, I think that may not be enough, because follow-up after stroke might need some kind of long-term, lifelong follow-up as to both to the mentioned needs, but also to the secondary prevention. And I think that this could be looked like some kind of opportunistic screening if the patients have been lost before. And at the moment, there's a lot of interest in health screening in Europe. And I think this is really a wonderful business case for this. So I think we need not only to think about what drugs to give, exactly what advice to give, but also to ensure that there's a system and organization that catches the patients and their carers and actually give them the opportunity of receiving and using the given advice, and also taking care of their other needs. So this is something which we really must discuss in the future.
This is very insightful, Hanne. Thank you for bringing up and highlighting the really high risk of stroke recurrence, and also overlook entities such as cognitive impairment in our patients. And as you said, that the risk doesn't stop at 3 months, but is a continuous, unfortunately for most individuals, a lifetime risk. So there is a growing interest in more specialized roles, such as the stroke lipid specialist. So I would like to ask you if you can share your experience with this kind of model, and let us know whether it has improved patient outcomes or workflow in your center, and taking a step forward, whether you think a model like that or similar models can help tackle some of the challenges that were nicely presented by Hanne.
Yeah, thanks very much. And it leads on quite very nicely, actually, from what Hanne was saying, which is the importance of empowering and educating the patient to know what they should or should not be doing, how they should or should not, take medications and be compliant, etc. And there are certain aspects of stroke prevention which are very well done. So, for example, anticoagulation for AF, blood pressure control. People know the routine pretty well, especially in the hyperacute stroke setting, in the hospital setting, in the secondary care. And the primary care are also now very well versed in anticoagulating for AF and BP control. One thing which I feel, and I think that is backed up by a lot of observational data, is lipid lowering is not as closely monitored after the acute stroke event. It's very common to find that when patients are discharged from the hyperacute stroke unit, there is this fire and forget approach, starting, for example, atorvastatin 80 milligram and then discharge. no one tends to be taking responsibility to repeating the blood tests, escalating the medication dosage, maybe adding or changing the medication in order to reach the treatment target. So depending on which country you come from, maybe your primary care is much better developed. But in the UK, we are finding that no one is really taking responsibility in repeating the bloods, checking whether they are taking the statins and the other medications, or titrating up towards the target. There is also, as you know, a lot of social media negative posts about statins. So that is what the patient and the family are seeing probably on a daily basis on Instagram or Facebook, telling them not to take statins, or the very high risk of taking statins, which are not true, and then not telling them the real benefit of taking statins and lipid lowering. So we audited our pathway with 100 patients coming through a hyperacute stroke unit, and we found that only 7% of our patients at follow-up reached LDL treatment target. 7% out of 100 people. And the follow-up is at about 6 to 8 weeks. So one thing that we did was to redesign our pathway and redesign our approach, which is to use allied health professionals and not just relying on doctors changing practice or the primary care. So we employed a stroke lipid nurse to oversee the education of every new stroke patient coming through the hyperacute stroke unit, doing lifestyle education, explaining about what statins do and not worry about the side effects too much, explaining about not just lipid lowering, but all the other important aspects of lifestyle education, such as giving up smoking and weight optimization. And then we added lipid clinic associated with our stroke follow-up clinic. So the nurse had his own clinic, and also I added a stroke lipid clinic, which is separate especially to give the injectable therapy according to guideline. We also used a point of care machine to do a finger prick test for lipid blood test. So we get the LDL, the total cholesterol, and the triglycerides within 1 or 2 minutes of testing the point of care machine in the clinic. So we have instant feedback for the patient. Look, the tablet you're taking is really working well. Please carry on with it. And they feel this empowerment. Or, look, you're taking this medication and it's not quite getting towards the lipid target. So we need to add another one because we are trying to get down to, say, 1.8 or 1.4. The patient feels much more involved in that because they see that finger prick test result straight away. And the consultant or the medical person can make that immediate decision, which is useful, rather than writing a letter to the GP that hopefully gets read in the next few weeks, and then hopefully something happens with a change of medication. What we found with this kind of pathway redesign, using a new stroke lipid specialist nurse, our target, the patients reaching LDL target at follow-up went up tenfold to 72% at follow-up. That is actually comparable to some of the PCSK9 inhibitor trials. 70% reaching LDL target. That is just by adding a nurse to improve the education, improve the pathway, and to add the point of care machine. So I think I think what Hanne said was really, really good, which is to have a system, is a systematic way of making sure the patient knows what they're doing. So, for example, even just getting a blood pressure machine at home, doing the blood pressure measurements at home, to know their numbers, to know their lipid numbers, know their BMI, know the blood pressure, the fluctuations during the day, and the importance of that compliance with medication. Because as we know, a lot of patients, we give the medication, we say, take it, receive in 3 months. And we know that a lot of them, their compliance drops off over time. So I think a systematic way of reminding them the importance of carrying on and reducing the risk of stroke, not just in the first few weeks, months, but years and years later, is really, really valuable. Yeah. Thank you.